Yeah, you can
when you're ready.
ready. Yep. Okay.
Are you sure you don't have to? No kidding.
Awesome. Great. Good afternoon, everyone. Welcome to Medical Grand Rounds. Dr. Buller and Dr. Zarich send their regrets and asked me to introduce our speaker, which is my honor. Dr. John Cockcroft is our speaker. He comes to us from Cardiff in the United Kingdom. And since he's already tried to hire Jerry away from us, I've told Jerry that the climate in Cardiff is actually pretty crummy, so he shouldn't take that job. Dr. Cockcroft, in case you're wondering, is not related to the Cockcroft of the Cockcroft and Gault formula, but he is related to a Nobel Prize laureate who was involved in splitting the atom. I'll let him tell that exact story. But it's quite an interesting background. He has a background not just in medicine, but also in biomedical engineering, and became interested in a number of years ago through contacts. As medicine goes, you run into people who change your directions in life. In this concept of measuring the blood pressure in the body, not by the arm and the brachial artery, but from the central aorta itself, and was instrumental in developing such technology, which he's going to explain to us. And by the end of the hour, we should all be smarter about why we should be monitoring central aortic pressure instead of the brachial artery pressure in treating hypertension. Thank you very much for joining us today. It's an honor, sir.
And I'm going to turn this on for you.
Good afternoon, ladies and gentlemen. Before I start, it's exactly the same on our side of the pond now that regulations declare that I should make clear any relationships that I have before giving you this talk. Well, I have to declare that I love New York, and I've been in a relationship with New York for 20 years. I would, of course, love to declare that I'm in a relationship with Taylor Swift, but unfortunately, I can't do that. So you heard from the chairman that I come from Cardiff. Well, some of you may not know where Cardiff is. And this is my badge from the American Heart Association meeting a long time ago, and I've still got this in my office. And I was a little worried because at that time George Bush was in the White House, and I thought I could actually be responsible for the complete annihilation of a city of 1 million people. And fortunately, when I flew back from that meeting, I didn't land in Guantanamo Bay. I managed to get back to the UK. So I'm going to talk to you about a paradigm shift away from measuring blood pressure in the brachial artery to measuring it in the aorta. And a paradigm shift was defined by Thomas Kuhn in a way that's appropriate today, that scientific advancement isn't evolutionary, it's a series of peaceful interludes that are punctuated by violent revolutions, and then in those revolutions, one conceptual idea is replaced by another. And the classic paradigm shift, of course, is Galileo. Before Galileo, because we were all arrogant people living on Earth, we thought that the sun went round the Earth. But of course, Galileo said, well, actually, that's wrong. The Earth goes round the sun. And of course, he was told to shut up or he'd be killed and retract. And as he was led away to house arrest, he said, well, I don't care what you say, it does. And of course, there are still some people who think that the Earth is flat, but fortunately, they're still in institutions. So I'm delighted to show this slide because this is supposedly the first measurement of blood pressure. And it was done in 1733 by Stephen Hale. And Stephen Hale was a vicar. And in those days, vicars were very rich people. So they lived in very big houses and had a lot of money. So they were the only people capable of doing research because they didn't need grants. So there was no NIH or MRC there. These people did it because they were rich. And not much has changed because Hale is not doing any work like most professors, and the research fellow here, his groom, is doing the work. And what they did is they put a tube into a horse's carotid artery and it rose up the tube. So of course they were only measuring systolic pressure, not diastolic, and of course this was very unlikely to get through an IRB. But it's supposedly the first measurement of blood pressure. And then in 1872, along came this guy, Akbar Muhammad, who worked at Guy's Hospital in London, where I've worked myself, and he invented the machine called the sphygmograph. And essentially, it was just a little pressure plate that rested on the radial artery. So you got a tracing of the radial artery. And you can see here, this is the tracing of someone who is fit and healthy, and this is the tracing of someone who is very unwell. And in fact, because he worked at Guy's, this person had hypertension and renal disease, had Bright's disease, in fact. So he was using this system, but he couldn't get any numbers. He could get nice tracings, as I've shown. And Lord Kelvin, who was then head of the Royal Society, said, when you can measure something, this is a bit vicious. When you can measure something and can express it in numbers, then it's meaningful. When you can't express it in numbers, your knowledge is of a meager kind. So he was basically politely saying that Muhammad was, just a country boy who didn't know what he was talking about. And as I said, Lord Kelvin was president of the Royal Society, but he wasn't so hot himself, because if you look at some of the things that he said, radio has no future, X-rays will prove to be a hoax, and heavier than air flying machines are impossible. So, that will put paid to a lot of medical conferences, although maybe Boeing might agree with him at the moment. So he invented the forerunner of the modern sphygmomanometer, and of course you could get numbers from this. You could get systolic and diastolic blood pressure, but what he was doing is he was throwing all this information that was contained in the waveform that Muhammad was measuring, he was throwing that away in favor of numbers, systolic and diastolic. And he died old and rich because he made a lot of money. Muhammad, unfortunately, died young and poor, so not much has changed. And these two gentlemen were prominent in the American Heart Association, and in 1931, White said hypertension may be an important compensatory mechanism which shouldn't be tampered with, even if we were certain we could control it. And Hay went even further. The greatest danger to a man with high blood pressure is its discovery, because then some fool is certain to try and reduce it. Well, I hope Hay is spinning in his grave wherever it is, because I fully declare that I'm a fool, and I'm glad that there's still a lot of fools left, because we know very well that it's important. And I would also like to say that science drove the introduction of blood pressure measurement into clinical practice, but sadly I can't, because it was what drives everything these days: money, filthy lucre. Because in the 1930s, the MetLife insurance company realized that systolic and diastolic pressure predicted heart attacks, stroke, renal failure. So they said to the doctors, you've got to measure it. And the doctors said, why? And they just said, because if you don't, we won't pay you. And the rest is history. It was introduced into clinical practice. So I talk at insurance company conferences and I tell them that, they've saved millions of lives. I don't care how much money they make as long as it's beneficial, which it was. So the history of blood pressure is an interesting one. The first measurement in 1733, and then it wasn't until 1967 that the first trial was done. This is what actually introduced blood pressure measurement into clinical practice, the MetLife data, and then we had a number of drugs, but the first trial was 1967. So if you look at the introduction of the sphygmomanometer to the first trial, it was 62 years. That is a long time, and hopefully nowadays things don't take that long to get sorted out. So this piece of apparatus is approximately 45 years old. What do you think it is? Well, it's the first mobile phone. And people my age will remember when you got a visit from a drug company CEO, his secretary used to carry a sort of heavy bag which had his phone on. It was like sort of, you know, colonels in the army. This is now where it belongs, in a museum, in the Hermitage Museum in St. Petersburg, where it firmly belongs. Again, I'm showing my age because this is my first computer. It's a Macintosh Classic. Well, every one of you with a smartphone's got 50 times the computing power of this. Where is this at the moment? It's currently in my closet because I'm going to be showing it on the Antiques Roadshow soon, and hopefully going to say, wow, this is an amazing piece of apparatus. So the next piece of apparatus I'm going to show you is over 100 years old. And it's the sphygmomanometer. This is obviously a mercury one, but versions of the sphygmomanometer are in everybody's outpatient clinic, and yet it's 100 years old. So don't you think that, like the mobile phone, like computing, we could have moved on from using a brachial cuff, which is 100 years old? You'd have thought we could have moved on. Well, this is more up-to-date data because I'm not saying that systolic and diastolic pressure in the arm aren't predictive. They are predictive, and we know that. This is the Lancet paper in over 1 million people showing that blood pressure, both systolic and diastolic, is related to stroke. The younger you are, the steeper the relationship, but there's still a relationship in older people. And if you look at heart attack, exactly the same. There is a relationship between systolic and diastolic pressure and a heart attack. So I'm not saying that you should completely abandon measuring pressure in the brachial artery, because it is predictive. And we know that if you lower blood pressure, and this is data from nearly 50,000 patients in 17 trials, that you reduce the incidence of stroke and coronary heart disease. And we know that every decade, from the introduction of sympathetic blockers through to direct renin inhibitors, there's been a new drug developed to treat hypertension. So I don't know what it's like this side of the Atlantic, but when I was a young doctor, very attractive women with leather briefcases and Armani suits would come to see me, and they'd tell me that it wasn't the drug, it wasn't blood pressure reduction that was important. It was using the right drug, which was clearly their drug, you know, Wonderlol. And we had adverts where you had like the Colgate ring of confidence round your heart. So they were telling you, forget, you know, what you need to do is lower blood pressure with my drug. And so there's been a big debate about, is it the drug you use for blood pressure reduction, or is it lowering the blood pressure that's important? And you guys know the answer to this because this is the biggest trial that's been done. And this was the All-Hat trial. And they compared early drugs like chlorthalidone with amlodipine and lisinopril. And there was absolutely no difference between the three drugs. So the evidence here was that it was lowering the blood pressure that was giving you the benefit and not the drug that you use. The drugs were equally effective. And this is data from Jan Stayson, fairly old now, but he reviewed all the trials and there was absolutely no difference in terms of cardiovascular events, in terms of what drug you used. And the same for fatal and non-fatal stroke, no difference in the drug you used. Blood pressure reduction. So Stacen said that the hypothesis that the new antihypertensive drugs might influence cardiovascular prognosis over and beyond their antihypertensive effect is unproven. And again, this is an analysis of Stacen looking at angiotensin II blockade. And in the trials that used angiotensin II blockade, there was a suggestion that it was better in terms of reducing stroke. And so this paper that Franz Messerli was involved in looked at drugs that change angiotensin II formation and outcome. And they suggested that drugs that decreased angiotensin II levels, like beta blockers and ACE inhibitors, were less effective than drugs that actually put angiotensin II levels up, such as angiotensin II receptor blockers or diuretics. Potentially, this may be due to the fact that angiotensin II may be acting on angiotensin II receptors to producing benefit. And many of you in the audience will know that people like Thomas Unger are deliberately developing drugs that are agonists at the angiotensin II receptor to try and address this issue. So is there benefit beyond blood pressure reduction? Well, the first trial that suggested there was benefit beyond blood pressure reduction is this trial that everyone will know, the LIFE study, which compared a beta blocker, atenolol, an older drug, with a modern drug, losartan, an angiotensin II receptor blocker. And you can see that the two drugs, in terms of systolic, mean and diastolic pressure, did exactly the same. But remember, blood pressure was measured in the brachial artery in these studies. But despite them having similar effects on blood pressure, there was a benefit in the losartan treated group in terms of the composite endpoint, death, heart attack, or stroke. Of course, the clever people in the audience, and that will be all of you, know that there was no placebo in this trial, so it could be equally that beta blockers were worse than losartan, rather than losartan was better than atenolol. And all the benefit in the LIFE study was really in terms of stroke. So there was a benefit, but it was in terms of stroke, not heart attack. So of course, MSD suggested, yeah, this is it. It's use our drug. It's got benefit beyond blood pressure reduction. But remember, as we're going to come on to, they were measuring blood pressure in the arm. So usually, if I'm giving this at an evening lecture, I'll have a nice glass of Italian wine, which is halfway up the glass. And of course, that glass could be half full or half empty. And of course, if you work for Merck, Sharp and Dome, it's of course half full. If you like to be more skeptical, it's half empty. So there's no answer to that. So what about central blood pressure? Well, we know that guidelines on both sides of the Atlantic get a lot of flack. And I'll be a little careful what I say, because I know that your guidelines on this side of the Atlantic in terms of hypertension they could have been written by Donald Trump. I mean, you put up the guideline, and then 2 weeks later, two people who are on the guideline paper say that they don't believe in the guidelines. So guidelines get a lot of flack, and they're usually wrong. So I'm going to show you the European guidelines. And for those of you in the audience who don't know, yes, we're still in Europe. So the European guidelines, for once, as I'm going to show you, got it right. So the European guidelines said that aortic blood pressure, the pressure exerted on the heart and brain, may be different from that measured in the arm and be a better predictor of outcome and may be differentially affected by antihypertensive drugs. I'm going to show you evidence that every single one of those statements is true. And whether you like it or not, from the day you're born to the day you die, your heart and brain don't see the pressure in the arm. They see the pressure in the aorta. That's what the heart's beating against. That's what the kidneys see. That's what the brain sees. I, unless I'm mistaken, have never seen an arm attack. I mean, if I had, clearly I would be putting a case report into the New England Journal. But I don't think anyone's seen an arm attack. They've seen lots of heart attacks. So let's go through this. Well, I had a quick talk with your chairman before coming in to give the talk. And strangely, I'm not an invasive cardiologist, because with the exception of things like EP and ablation, there's virtually zero evidence that what the cardiologists do has any benefit beyond their bank accounts. So we'll draw a veil over that. But the invasive cardiologists 50 years ago had data that the pressure in the arm was up to 50 millimeters different from the pressure in the aorta. And this was invasive pressure lines. And they said, wow, this is interesting. And then they said, do you think we can commercialize this, make any money from it? And they said, probably not. So they forgot about it for 50 years. So here's the data. And this is the difference between radial pressure and pressure in the aorta. And you can see little difference between the radial and the aorta in terms of diastolic or mean, but huge differences in systolic pressure. So why are there differences? Well, it's amplification. It's just like the sort of thing that occurs in your stereo system. The signal gets amplified. If you take a piece of string and you waggle it, the waggle at the end is greater, isn't it? There's amplification. You're on the freeway, you wonder what the hell is causing the jam. And of course, there isn't anything causing the jam. It's just traffic slowing down and producing the effect. So there's an amplification of the pressure wave from the heart as it goes out towards the periphery. And of course, there's a fall overall of 2 millimeters of mercury, because clearly blood, like water, doesn't flow uphill. And I commend this review to you. It's in the European Heart Journal, not just because I'm on it, but it is an up-to-date review. And we've shown that this amplification really is present throughout life. Obviously, as you're getting older, your aorta is getting stiffer, you're damping down that amplification. But I reckon you'd probably have to be 102 before your systolic and your systolic in your brachial was equivalent to the systolic in your aorta. So until relatively recently, the cardiologists would have loved it, because the only way you can measure aortic pressure would be to put a catheter in through the femoral artery or the radial artery, stick it into the aorta and measure the pressure, and charge people for doing it. But as I'm going to show you, and what's driven the field, is that we can now measure central pressure non-invasively, either from the carotid or the radial artery, and there's even, as I'm going to show you, cuff-based systems. So I can take you into my consulting room, I can sit you down fully clothed, put a tonometer on your radial artery and measure your aortic pressure within 1 millimeter of mercury with that I measure with an invasive catheter. So in terms of the invasive measurements, I can get within 1 millimeter of mercury simply by putting a pressure sensor on your arm. And there's a lot of systems out there to do this, but they basically work on the same technology. There is a non-invasive recording of pressure waves, so clearly you have to do it in an artery that's accessible, the carotid, the femoral, the radial. You then collect that waveform, you subject it to mathematical analysis and quantification. Basically, you break it up into harmonics, subject it to Fourier analysis using a transfer function, and when you do that, you can generate central pressure either at the aorta or the carotid. You can look at wave reflection, because remember, the aorta isn't an open system. That pressure wave from the aorta gets reflected back towards the heart from reflection sites lower in the body, and you can measure arterial stiffness in terms of pulse wave velocity. But of course, for the purposes of this talk, I'm going to focus on central pressure. So this is one of the early systems, the sphygma core system. So this was, the early system was called the sphygmograph. This is the sphygma core system developed by Michael O'Rourke and his colleagues in Sydney and Australia. And I was privileged enough to be in Michael's lab when Michael and Albert Alvolio were actually generating data and refining this system. So one of the early traces, I'm pleased to say, is mine. So basically, you record the pressure waves from the radial artery, and you'll see that this is exactly the same sort of waves that Muhammad was getting hundreds of years ago. But this time, we can quantify them and come up with numbers. So this is the aortic waveform derived non-invasively from the peripheral one. This first pressure peak is due to ventricular ejection, and this second pressure peak here is due to wave reflection from the periphery. So that you guys all knew about hemodynamics when you were kids, because you all played the game in the bath where you slid forward, made a wave, hit the end of the bath and came back and splashed all over you. Some of you will be denying it, but I know you're lying, okay? So that was a good game. And then you realized that if you slid forward more forcefully, that wave traveled faster, hit the end of the bath sooner and came back and splashed all over you. And that's exactly more or less what's happening in the circulatory system. When you've got a stiff artery, the forward-going wave travels faster and comes back faster and at a greater magnitude. And it comes back when the aortic valve is still open. So you get a secondary rise in pressure due to that wave reflection from the periphery. And that can be recorded as the augmentation pressure in millimeters of mercury, but most people record it as this increase in pressure over the pulse pressure as a ratio, and that ratio is called the augmentation index, and that's essentially a marker of wave reflection from the periphery. And this is the consensus document from Europe, over 10 years old now. We're trying to get another one together. And basically, the position statement was that it's inaccurate to use brachial pressure as a surrogate for aortic or carotid pulse pressure, particularly in young people, because clearly young people have got much more amplification. Now, if the amplification was exactly the same in every individual, we wouldn't need to really worry, because we just introduce a correction constant and we'd be able to calculate central pressure from the brachial pressure. But we can't. So this is central pressure data. This is from the French group of nephrologists, from Michel Saffar's group. And of course, people used end-stage renal failure for the worst reasons, of course, because they knew they were going to get a lot of endpoints. They get a lot of endpoints, so you don't need to study them for a long time before you get some hard endpoints. And they broke the patients up into tertiles of central pressure, and this is the probability of survival. If you had a high central pressure, you were virtually all dead by the end of the study. Now, I would love here to say, because the Americans were fairly late to catch on to this, I'd actually love to say that the first trial that showed that central pressure was better than brachial pressure was an English one. Unfortunately, I can't. It was an American one by Mary Roman and colleagues, and this was data from the Strong Heart study, and they showed in this paper in Hypertension, this is brachial pulse pressure, this is central pulse pressure, that central pulse pressure was significantly, not highly, but significantly more predictive than pressure in the arm. And this is followed by this systemic review and meta-analysis by Charalombos Vakoupelos and colleagues, again showing that central pulse pressure and systolic pressure tended to be better than brachial. I tell you, because it's been a very, very long time coming, any of you who've tried to do individual patient meta-analysis, go and have psychotherapy first, because you can get the data, and then when you try and publish it, everybody's sticking their 5 pennyworth in about, you know, what should be in, what should be out. There is finally going to be a paper out from an individual patient meta-analysis showing very, very clearly